All right, here we go. Hello, everyone. My name is Dr. Marty Kotler. Thank you for attending this webinar on DCNP integration. Just a little disclaimer. The information in this presentation is for educational purposes. It's not intended to be a substitute for your thorough clinical decision making. It's not intended to be a substitute for your billing protocols. It's not intended to be legal advice. Target coding doesn't provide legal services. CPT is a registered trademark of the AMA, and every attempt has been made to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Now, we have a lot of people listening to this presentation today. Some of you are members of Target Coding. Some of you are past attendees of our webinars and seminars. And some of you have no idea who I am. So let me tell you a little bit about myself. Again, my name is Dr. Marty Kotler. I'm a chiropractor. I practiced for 16 years prior to starting my company, Target Coding. I'm a certified professional compliance officer, certified billing and coding specialist, and my company's been helping thousands of chiropractors and their staff members for over 14 years. My specialty is in compliance as it relates to billing, coding, documentation, Medicare, HIPAA. I've written many training manuals on chiropractic billing, coding, and documentation. I write articles to the major publications and magazines you see coming across your desk, like Dynamic Chiropractic, the American Chiropractor, what else? The Chiropractic Economics, and I'm a guest speaker at many state association conventions nationwide. Now, I consider myself kind of unique because most chiropractors are not certified coders. Most certified coders are not chiropractors. So you'll see during this webinar how I combine both specialties to make sure you're doing things properly, you're complying with laws and rules, and you're getting reimbursed what you deserve. So let's begin with DCP integration. Let's talk about the pros and cons. Now, there are some companies out there that are multi-specialty consultants and practice management consultants, and they'll tell you all the positive things. They'll paint this rosy picture. I'm not going to do that. I'm going to tell you that there are pros for sure, but there are negatives, and I want you to be aware of them. Overall, this is a great thing to do, but you should be aware of some of the negatives. So the positives, it's a great way to co-treat patients. You're going to definitely add another clinical approach to the practice. You're going to add more services very easily. Once you bring on a nurse practitioner, it's like adding a whole nother department to your office. Bringing on an associate chiropractor is much different than bringing on a nurse practitioner, a totally different discipline. It's going to give you the opportunity to give you much more ability to get new patients and marketing opportunities. You know, you may be in practice for 20 years. If you've never gotten a referral from the local medical doctor, now you bring in a nurse practitioner doing joint injections, and now all of a sudden the medical doctor's referring you patients. Yeah, things like that are going to happen. The negatives, you're going to have more expenses. You're going to need to have a few bucks in the bank to be able to handle this. For example, a nurse practitioner, you may have to pay the nurse practitioner $1,000 a week, maybe more. Do you have that? I was just talking to a chiropractor from Minnesota. He wants to bring on a full-time medical doctor. I told him how much it's going to cost and what the expenses are, and he's like, I can't afford to pay a medical doctor $200,000 a year. So that was basically the end of the conversation. So there's additional expenses. There's malpractice costs. There's maybe more overhead. You may need more room. I have a doctor in New York City. He has 450 square feet. He wants to integrate. We can't. He doesn't have enough room. It's going to add more work to your existing staff. When I integrated, I was chiro only for 12 years. Then I integrated. Some of my CAs that were used to me, I was their only boss. And now I bring on nurse practitioners, medical doctors, physical therapists, and now these are partners in the office. And now they're telling my staff what to do. Some of my staff members didn't like my partners, so they quit. Yes, you might have staff turnover. It might be hard to find certain parts of the country. It's hard to find nurse practitioners. A little bit about nurse practitioners, just a few statistics I want to share with you before we get into specifics. Nurse practitioners, there are approximately 270,000 nurse practitioners in the United States. It's a lot. about 70,000 chiropractors, about 1 million medical doctors, 200,000 physical therapists, about 65,000 physical therapy assistants. So nurse practitioners have an advanced degree. Some states call it an APRN or just an NP. You know, there's different titles, but it's a professional degree. The average salary is about $80,000 for a nurse practitioner. Now, if you're in New York City, you're probably going to have to pay more than Omaha, Nebraska. Nurse practitioners are licensed in all states, and they practice under the rules and regulations of the state in which they're licensed. Nurse practitioners can do a lot of things. They could be wellness nurse practitioners. They could be specific nurse practitioners. My wife, she goes to a dermatologist for certain things. When she goes there, she doesn't see the MD dermatologist. She's always seeing the nurse practitioner who specializes in dermatology. If you bring that type of nurse practitioner into your practice, this nurse practitioner is going to have to get trained because they don't know anything else besides dermatology. Not a big deal, but you know, they could focus on a lot of things: disease prevention, health education, counseling. They can guide patients in making smarter health and lifestyle choices. They could initiate care plans. They could recommend services. They're allowed within their scope to do trigger point injections, joint injections. If you wanted your nurse practitioner to do plain old simple mechanical traction or oversee a patient doing rehab, it's within their scope. Medicare will even pay for it. So there are state-specific requirements when it comes to nurse practitioners. Some states have full practice where the nurse practitioner doesn't need MD collaboration. In some states, it's reduced or restricted. So before we get too deep into this legal stuff, I want to bring on our guest presenter today. He's an attorney. His name is Matthew Levy, and I am now going to bring him into the presentation. I'm going to bring up his slides. Matthew, are you there?
Yes, I'm here. Thank you, Marty. First of all, I want to thank you very much for inviting us to this presentation. And we want to just take a quick moment, introduce the firm, myself, what it is that we do, and then get into, dive into, the main topic of today, which is chiropractic and nurse practitioner joint ventures. So first, the law firm of Weiss, Zarif, Rothman, Sonneklaar, and Levy is a law firm that has a concentration in healthcare law and business law, although the majority of the work that we handle at this firm is healthcare related. We are basically a full service law firm for healthcare providers, handling whether the most basic document could be employment contracts, the most complex could be buy sells of publicly traded healthcare companies, and everything in between, whether it's the structuring, like we're talking about today, of a partnership, corporations, the breakup of those. We also handle healthcare fraud, billing fraud investigations, the insurance company audits, commercial litigation, various issues. I don't need to, bore you with all those details. Myself, I am one of the owners of the law firm, so I'm a shareholder as well as a director at the law firm. And I'm doing this for approximately 24 years. I would like each of you to take advantage of today's discussion, as there's going to be a lot of information and laws that are going to be discussed and laid out for you. And take advantage of today. It's not often you get to speak to a healthcare attorney for free, or a certified coder. So take advantage of that. It is really a great program. Just before I get started here, you go to the next slide. I just want to be clear, although Marty may be talking, from a national standpoint, my talk is really limited and geared towards New York State. So with that said, let's dive right in.
You know what, Matthew, I was just going to tell our listeners, I don't know where everybody's from, but if you're not from New York, that's okay. Stay with us, because a lot of the things that Matthew is going to be discussing could apply in other states. So don't think this is just a New York thing. The codes for trigger point injections are the same nationally. The codes for back braces are the same nationally. So a lot of the things that I'm going to be covering could be used in all 50 states. But, I just want to share with you, this is not necessarily a New York specific webinar. So now I have a question for you, Matthew. Are you licensed in any other states?
Yeah, so, well, as a firm, right, so I mean, me specifically, I'm licensed in the state of New York, Pennsylvania, and DC, but we have attorneys and I have partners that are licensed in the state of New Jersey and Florida as well. And again, our recommendation would be that if you are, entering into a transaction similar to what, we're talking about today, that you should seek the advice of counsel, from, that state or that is licensed in that state. And of course, that is familiar, with the rules and regulations associated with this.
Well, we definitely have people on from New York, New Jersey, Florida for sure, Illinois, Georgia, Pennsylvania for sure. So yeah, we have a nice mix.
All right, very good. So with that said, in New York, we have something called the prohibition against the corporate practice of medicine. And this doctrine, again, I don't know the exact number of states, that this applies to, but it's a significant number. For our discussion purposes, let's say it's close to half of the states within the United States. And basically what the prohibition against the corporate practice of medicine says, and then again, I could do a presentation on this topic alone for an hour, but to sort of, really make a long story short, it basically says that a layperson or one without a license, cannot be partners with one that has a license. So some examples of that, Marty has indicated that he's a licensed chiropractor. Well, and I'm a licensed attorney. Well, Marty and I can't be partners in our respective, businesses, right? He can't be partners in my law firm. I can't be partners with him in his chiropractic practice, right? Now, in that hypothetical, we both have licenses, but we don't have similar licenses. So the prohibition against the corporate practice of medicine prohibits those type of relationships, and more specifically, or more, in addition to, it prohibits one without a license to be in control and to be partners with someone that does have a license. Now, there are some exceptions to those rules, and we're going to get into those and dive into those in a little bit. So there is I believe, a 50-state survey, and you can look that up. I think it's, we can give you that email if you're interested, so you can have an understanding of which states this applies to and which states it does not. So for those states that do not have the prohibition against the corporate practice of medicine, well, the rules are very, very different. It's sort of a lot looser and a lot less regulated, whereas a layperson without a license could actually own the chiropractic practice perhaps, and be partners with them as well. Okay, next slide, please. We'll go one more. Oh, hang on one second. So, and you can look on here, there are some websites for you to, look at and click on, so you can take a look and see, some of the, the issues that we're talking about, as well as the laws related to this as well. Okay, next slide. So now we're going to, delve into, sort of like the nuts and bolts of, assuming that you're, in a state that has this, prohibition against the corporate practice medicine, or like I was saying before, let's say you're in New York, we have options here when we're providing professional services, right? So you really need to form that entity under either the business corporation law, which are, PCs, professional corporations, or under the limited liability company law, which are PLLCs, professional limited liability companies. Now, what's interesting here in New York, right, under the business corporation law, it basically doesn't allow for different subspecialties to be partners with, it's not different subspecialties, but different licenses to be partners with each other. In other words, a physician cannot be partners, with a chiropractor. A chiropractor would not be able to be partners with a massage therapist under the business corporation. However, under the limited liability company law, which for whatever reason, a chiropractor could be partners with a massage therapist or could be partners with a nurse practitioner. But under the business corporation law, even within the same state, they cannot be. Now, why that is, that part I can't answer for you. All I know is that under the limited liability company law, the nurse practitioner and the chiropractor can, in fact, legally form and own that entity. Now, we have to be clear that they do, both licenses have to have an ownership interest in the entity. If one of those licenses, one of those partners should leave that partnership can no longer function unless and until another licensed professional with that same license is introduced and becomes an owner of that entity. So as an example, if the chiropractor and nurse practitioner form the PLLC and the nurse practitioner leaves, that entity is no longer able to function and provide professional services, at least not for the nurse practitioner services, right? You can still perform the chiropractic services, but not the nurse practitioner services. So there would have to be either a new nurse practitioner would come in place, or really that entity really is going to become defunct as a DC NP PLLC. All right, so I just wanted to be clear on that. Now, when we form the PLLC, there are differences between the limited liability company law and the business corporation law. Just as an example, under the business under the PC, under the corporate, formation, there would be something called a certificate of incorporation. Whereas under the limited liability company law, there's something called the articles of organization. So although they have two different names, they're pretty similar. It's basically the, formation documents of the entity, which gets filed with the state. Now, once that is done and filed with the state, that the approximate time frame, by the way, from the time that you fill out those documents and submit them to the state for approval, is somewhere between 14 to 17 weeks at this time here in New York. That time frame pre-COVID used to be about 4 weeks. Now, let's talk about the names, just so you have an understanding also if you're going to take this to the next step and actually proceed with organizing under this type of a structure. The name has limitations as well. So you are obligated, when you're using the name, to have both professions named within the title of the organization. So let's just use ABC, as an example, is the name of our company. It would have to be, ABC Chiropractic and Nurse Practitioner, PLLC. But more specifically, with the nurse practitioner portion, it has to specify what their subspecialty is. So it may be family medicine, it may be geriatric, it may be surgery, whatever it is that the nurse practitioner is going to participate in within this particular entity, that has to be within the name as well. Also, just to give you some additional information, the word center cannot be in the name, center or clinic. Center or clinic within the state of New York is designated for organizations that are formed under Article 28 of the Public Health Law. So those would be like ambulatory surgery centers, diagnostic and treatment centers, hospitals, things like that. Okay, so that's a little bit of information as to the formation of the professional partnerships. And we can go to the next slide. Okay, so as you can see here, right, there is a list under the limited liability company law. And if you go to the second bullet point, you'll see that this is the list that is excluded professions, that even under the limited liability company law, these professions cannot be partners with each other. And based on the way that this is crafted or drafted, right, we're able to, indicate that, professions that are outside the scope of these listed entities or these professions, right, those other professions can be joined or put together within the limited liability company that you're forming. Now, an interesting note, we in the past have formed physical therapy and PTA PLLCs, and New York State has just recently pulled that, and so you can no longer actually form a PT PTA PLLC. And I know that that's not the topic of today's discussion, but I just want you to understand that these things can change over time. But at this point in time, the DCNP PLLC is a viable option and is one that you can in fact form. Okay, the next slide, please. So this is really the meat and potatoes of the structure of this organization, right? So, the first step is to draft the articles of organization and get that filed, with the state. And then under the LLC law, the limited liability company law, you are required in New York State to do two things. One, you must by law have an operating agreement, and two, you must publish in 2 periodicals. An example would be 2 newspapers for a period of 6 weeks, the existence of your organization. So, when clients come to us, we handle that entire process for the client and make that seamless, for the, as far as the client experience. But that just know that you are in fact obligated to perform those and get those done. If you do not, then your organization is not duly formed and you do not have the protections that come along with having, this limited liability company surrounding you and protecting you. So that's important for you to know. Let's talk about the operating agreement for a moment. So the operating agreement is really the controlling document as it relates to this particular structure. And the operating agreement, deals with numerous issues. They may identify who the managing partner is. Now it may be both, the nurse practitioner as well as the chiropractor. It may be one, not the other. The operating agreement will deal with death and disability and buyout. So it can be somewhat of a complicated document in the event that you really dive into all of those issues, or you can make it a very simple document, and really there may not be any buy sell, buyouts or anything like that. That is really very case specific and depending on the partners of each scenario. And we walk each client through this entire process. We let them know what is standard in the industry. However, your document does not have to be standard. It can be absolutely customized to what your wishes and desires are. Things that you do have to keep in mind though, and unfortunately, I have clients that come to me and they'll say, oh, I have a 99% ownership and I gave the nurse practitioner a 1% ownership. And again, where the government ultimately is going to draw the line in the sand and say, hey, that's not okay, but 50-50 is okay, or 70-30 is okay, or 60-40 is okay. What they're going to say is not okay. And when we are present in investigations by the U.S. Attorney's Office or the Attorney General's Office, is what they're looking for is, control issues and fee splitting issues and things like that. And what you have to be careful of is that you're not in a scenario where, let's just use a hypothetical that $100 comes into this PLLC, and let's say the nurse practitioner gets $1 and the chiropractor gets $99, right? That wouldn't be a fair market value, true arrangement, right? The government, in a scenario like that, would probably take the position, that this is really what they would call, well, they may say it's a scam or a scheme, so that's something that you have to be, cognizant of. So as Marty had indicated earlier, right, there's pros and cons, to everything that we do in life. And when you get into a structure like this, you have to understand that there is, there are some rules and regs and some reasonableness that has to be taken into consideration when forming, these types of entities and, handling this type of business when you're, dealing with multiple, or more than one license. So that is pretty much the gist of what I wanted to get across in today's discussion. If you have any questions, please, put them in the chat, and you can always reach me at my office, which is 516-627-7000, or you can email me at mlevy@weissarrett.com. That's MLEVY@WEISSZARETT.com. Again, I want to thank Marty for having me present at this presentation, and we are always available to answer any of your questions as it relates, whether it's regarding the formation of the nurse practitioner, chiropractic, PLLC, or if it's anything legally related to your day-to-day operations or compliance related to your practices. Just also as a side note, we are counsel to the New York Chiropractic Council in the state of New York, so we are very familiar with and represent a large number of chiropractors as well. Thank you very much.
Thank you, Matthew. That was an excellent presentation. I've heard many speakers over the years talk about this topic, and every time I listen, I learn something new. So excellent, thank you. I do have one question as far as like New York. A few of my clients have already asked me this question. Nurse practitioners, New York specifically, do they have full scope? Do they need to have MD collaboration?
So that's a great question. So, that, and I don't mean to sound like a lawyer and say that depends, right? So a nurse practitioner that's coming right out of school, the answer is yes, there would have to be a collaboration agreement. However, once, and I'd have to circle back with you, but I don't remember if it's 3,500 or 3,600 hours, something like that. But after the 3,600 hours is complete, approximately, let's say 2 years, they are able to be independent. They could actually form their own independent nurse practitioner entity and provide services, out there, and practice. But short of that, yes, there would have to be a collaboration agreement and some level of supervision, by a physician.
Excellent. All right, so stay with us. I'm going to take back the presentation now, and I'm going to go over a few things, and then we'll see at the end of the presentation if any other any questions have come in. So stay with us, Matthew. Thank you again for your presentation. So now, everyone, let's switch gears and talk about how do you find nurse practitioners? And once you find them, what do you say? What do you do? What are the conversations that go on? So one of the best ways to find nurse practitioners, ask your patients. I mean, anytime I needed anything in my practice, if I was looking for a car, if I had a patient that was a car dealer, I went to that person first. Needed an electrician, when I needed a physical therapist, I asked my patients. That's how I found one of my physical therapists. So ask your patients. You can contact local professional nurse practitioner programs, schools that offer the program, see if they have a job placement department. You can just call offices if you happen to know there's a nurse practitioner in an office near your office. Call them up, say hi. My name is Dr. Marty Kotler. I'm a local chiropractor. I'm looking to form a multi-specialty practice. I'm looking for a medical director or something like that. Are you interested? You'll be surprised how many people will say yes. If you want to use a job placement site like Indeed, now we're talking about money. You're going to have to pay for ads. Asking your patients is free, but a job placement site, a placement agency, that can cost thousands and thousands of dollars, but it could be worth it if you're having difficulty. And now if you're going to put an ad in the paper, here's some ideas. Great position to work in a state-of-the-art facility. experience desired but not required. You want to put in the amount of money you plan on paying them? You can write in the ad. You don't have to. Here's a question we get. Dr. Marty, why would a nurse practitioner or a medical doctor want to work for a chiropractor? Why don't they run their own business? What do they want us for? Well, you'd be surprised. Nurse practitioners, medical doctors, they might not want to run their own practice. Maybe they only want to work part-time. They would like to work in a group environment. They don't want to work in a hospital anymore. They're not entrepreneurial. They don't want to run their own business. They want a guaranteed income. I know a lot of chiropractors that would like a guaranteed income every week, like every Friday at 5 o'clock. Here's your check. I know some chiropractors, they they complain. 1 week's good, 1 week's bad. 1 week's good, 1 week's bad. Well, when you're paying someone a straight salary, people like that. No marketing. Try and find a nurse practitioner that's chiropractic friendly. When I got very busy in my integrated practice, we started getting sloppy, and we would hire people without vetting them properly. I remember one medical doctor, every time he saw a patient, these patients were not coming back. So I said to the doctor, what are you saying to these patients? So I'm looking at the records. Patients were coming in with simple back pain, neck pain. He's telling them to go home and take Advil. That's not what we do here, and it was our fault. We didn't train him properly. So you want to work with a nurse practitioner that understands that, is pro chiropractic. Otherwise, you could have some unusual conversations about the typical management, of a patient. Mention to the nurse practitioner during the interview, there's responsibilities here. Maybe it's not going to be as easy as your last job, but you're going to be responsible for evaluating, planning, and directing treatment outcomes, coordinating and delegating and supervising responsibilities. I'm assuming, these are the things that would go into an employment agreement. What is the nurse practitioner responsible to do? If it's an operating agreement, what is everybody's job description? That's one of the problems. I didn't have the jobs described properly in my partnership operating agreement with one of my partners. One of the partners in my integrated practice thought that he was doing everything he was supposed to be doing. And me and my other partners were not in agreement. He thought, by working 10, 15 hours a week, that was enough, and he felt like he was contributing his portion. Well, nobody else felt that way. But it wasn't delineated in the operating agreement who is responsible for what. It caused stress and tension. So when you're talking to the nurse practitioner, especially in the beginning, the beginning interview process, tell them what you expect. Tell them that you need to help us with training. We want you to understand and comply with our billing and coding policies and procedures. You're going to be doing trigger point injections. Do you know how to do them? I was working with one office, brought on a nurse practitioner. I'm doing the training with the nurse practitioner, showing the nurse practitioner how to bill, code, and document for trigger point injections. And the nurse practitioner says, wait, Dr. Kotler, I've never done a trigger point injection. I don't even know if I want to do them. Well, whoa, you've already been hired, vetted. Oh, wow, that should have been discussed earlier. Next, do you want your nurse practitioner in network? Are you in network? And do you want the nurse practitioner out of network or opposite? Well, in general, you're not typically allowed to mix under one tax ID. It's usually everybody's in or everybody's out under one tax ID. So when it comes to in network, out of network, certain things you should be aware of. You're bringing on a nurse practitioner, there could be some credentialing involved, then contracting. Maybe you want to have your nurse practitioner get certified in certain programs, go through accreditation. If you can get in, like I have a client right now in Arizona, brought on a nurse practitioner, fantastic deal. This nurse practitioner already has a Medicare number, already has a Blue Cross Blue Shield number, already has an NPI number, is bringing patients with her, so that's a great deal versus a nurse practitioner that just graduated. Wait, you got to do a lot more work. NPI, CAQH, Blue Cross Blue Shield number may be required, Medicare P10. So this is some of the credentialing process. Overall, in network versus out of network, I'm not going to tell you to join a plan. I'm not going to tell you to drop out. That's a personal decision you need to make. There's pros and cons to being in network, pros and cons to being out of network. So do you want your nurse practitioner in network? Big decision. Most of my clients are saying yes. Most of my clients are getting their nurse practitioner in network with all the plans and Medicare. So these are some of the applications. Now, these things, if they seem overwhelming to you, we can do them for you. Just to let you know, these are the things like Matt was talking about. You know, you have to put in the newspaper that you're making this, PLLC name, and so nobody objects to it. So that's something that a law firm would do for you. If you're looking to get your Medicare PTAN number for your nurse practitioner, you could do it on your own, or you could have someone else do it for you. Now, when it comes to patient flow, who is the patient going to see first? This is another question. So here comes Mrs. Jones. She walks into the office on a Monday morning. She has back pain. Is she going to see the nurse practitioner first, or should she see the chiropractor first? Doesn't matter. Ideally, I would like the patient to see the nurse practitioner first. And then the nurse practitioner could make recommendations about injections, physical therapy, chiropractic, nutrition, acupuncture. By the way, I'm not sure if Matthew mentioned it, but some of you may want to perform a PLLC with an acupuncturist. I think Matt mentioned chiro and massage. Maybe a chiro and an acupuncturist form a PLLC or a DC PT. Somebody needs to be the quarterback who's responsible for all the recommendations. They should be clear. So now, after you do your initial intake of forms, you get all out of the way, then just a little heads up, as far as the new patient codes, your nurse practitioner is going to be doing exams. So then you're going to be billing new patient codes. The codes, well, I shouldn't say the codes, the guidelines, the documentation guidelines for your new patient codes have dramatically changed. On January 1st, we have new guidelines, and it's based on time and decision making now. So if you're going to bill in 99203, it has to be at least 30 to 44 minutes, and it has to be documented in the notes. So you have to write down history 15, exam 10, and maybe 5 minutes to document. That totals 30 minutes. There's your 99203. So time includes speaking with the patient, examining the patient, reviewing records, documenting the encounter. Now, when it comes to decision making, if you're drinking coffee right now, take an extra sip, because when it comes to decision making, if you're going to use decision making to determine your new patient code, you have to become familiar with this chart, this medical decision making elements chart. There are 3 items: number of problems, the data to review, and the risk level. So in order to qualify for a particular code under the decision making, not time, 2 out of the 3 elements must be met. Let me give you an example here. 99204, based on time, that would be at least 45 minutes. So here's Michael Thompson. He comes in, he's a 34-year-old. Now he's going to see the nurse practitioner. So this is Michael Thompson coming in to see the nurse practitioner. So here's a sample new patient 99204 for Michael Thompson, who has a herniated disc. Nurse practitioner does a history. Nurse practitioner is documenting this patient has severe low back pain, needs to take frequent breaks throughout the day to rest his back. He stated started suddenly 5 days ago after being involved in an auto accident. So this is a sample auto accident here. He was taken by ambulance to the emergency room. An MRI of the spine was taken. The patient has never been in a car accident prior to this one. He has difficulty doing simple tasks. He's taking anti-inflammatory medication. He spends a large portion of his day sitting in his car driving. Ice helps to relieve the pain for a short period of time. So you get my point. The patient brought in MRIs. So reviewing the MRIs and the history, nurse practitioner, that took 25 minutes. And then we do an exam, basic exam, history, palpation, range of motion, tissue, tenderness, brief mental assessment, x-rays taken. So the exam took 15 minutes. And then we have the rest of the order, which is the diagnosis, schedule. Took 5 minutes to document this, so that totals 45 minutes. That's a 99204. Now, let's say you said, Dr. Marty, what happens if I don't want to spend 45 minutes, but I still want to bill a 99204? Well, if the patient qualifies, then use decision making. Here's the same exact SOAP note without the time components. So the note has to speak for itself. If you're going to bill a 204, an example of 204 is moderate level. So an example would be an acute complicated condition. I would consider a herniated disc a complicated condition. The data, well, we took x-rays, the patient had an MRI, risk level, it's low risk for morbidity. Mortality, what's the chance that Mr. Thompson is going to die from his herniated disc? He's not going to, so it's a moderate risk. Now, some of you may say, where are you getting all this information, Dr. Marty? Like when I do my live seminars, a lot of CAs, staff members, they come up on the breaks and they go, Dr. Marty, how do you learn all this stuff? Where do you get your information? So here, here it is. I'll show you if you're interested in becoming certified in coding. Start reading these books. I mean, I read like a maniac. I read these books all the time. I actually like reading these books. I know some of you are thinking, wow, you're weird. Yes, I am weird. I get it. We all have strengths and weaknesses. I enjoy reading these books. So when I talk about the E&M guidelines, like your 99203s and 213s, where do I get my information? From the E&M guidelines. They're available. You can Google E&M guidelines. The ICD-10 guidelines, your diagnosis codes, most of my information comes right from the ICD-10 guidelines and the tabular list that has all 70,000 codes. CPT codes I get right from the AMA. Why? Because the AMA owns the copyrights to the CPT codes. What they say counts. So I like to quote them when I'm fighting insurance companies. HCPCS codes, codes that start with a letter. I'll show you a few of those in a minute, like a back brace L0631. That's a HCPCS code. Read those guidelines all the time. HIPAA guidelines. Then we have Medicare guidelines. There's national Medicare guidelines, and then there's state-specific Medicare guidelines. I read those for all 50 states. The Medicare has something called the Benefit Policy Manual and the Claims Processing Manual, always referring to those. And then each individual insurance company, Aetna, Cigna, Blue Cross Blue Shield, they have their guidelines. Those of you from New York that treat workers' comp patients, you know there are workers' comp guidelines on neck and back pain, and you have to follow those. So that's where I get my information. There's a new code as of January 1st. There's a new code for a prolonged visit. This probably doesn't pertain to most of you, but let's say, I don't know, let's say you spent an hour and a half with a new patient. Well, 99205 is the highest level new patient code. So the time range for a 99205, I showed it to you earlier, is 60 to 74 minutes. So let's say you spend an hour and a half with the patient, that's 90 minutes. So you've gone 16 minutes over the high end of the range. So in that case, you could bill 99205 and 1 unit of 99417. Again, I don't think this applies to most of you, but I do have I have a client in Brooklyn, New York. Patients are coming in from other parts of the country. This particular chiropractor, patients are actually flying in from outside of the United States to see this doctor. And he spends 4, 5, 6 hours with the patient. They're staying in his office the entire day. So this is a very good code for him. Now, upon re-exam, the highest level re-exam code is 99205. The time range is 40 to 54 minutes. Well, let's say you spend 70 minutes doing a re-exam with a patient. You would bill 99215 and 1 unit of 99417. So if you spend, let's say you spend 80 minutes with a new patient, well, that's only 6 minutes above 74 minutes, so then you would not be able to bill a prolonged code. It has to be a 15-minute increment over the high end of the range. Now here's a HCPCS code, G2212. HCPCS codes that start with a letter. Now here, this is a situation where I just shake my head, and I don't understand it, but I don't make the rules, I just explain them. Medicare has assigned a status indicator of invalid to code 99417 and replaced it with G2212. So you're going to use this for your Medicare Part B patients. So for example, in New York, Medicare Part B, that's NGS, National Government Services. So patient goes to see the nurse practitioner. Nurse practitioner spends an hour and a half with the patient. Use G2212, 1 unit of that, and 99205. Now you might say, wait a second, Marty, I'm a chiropractor. Medicare Part B doesn't pay for exams. Yeah, so then you wouldn't need to use this code. Okay, so now let's get into some of these injections that are very popular in the profession now. Trigger point injections, large joint injections, amniotic fluid flow injections, PRP injections, stem cell therapy. Also very common. Try and cover these things too, some DME, physical therapy. Let's start with trigger point injections. So trigger point injections, these are areas of local spasm inflammation. There are the CPT codes. Very common code 20553, multiple trigger points, that's 3 or more muscles. Pretty straightforward. Most nurse practitioners are okay doing these. The first, I had an osteopath doing trigger point injections. By the way, we did trigger point injections with Traumeal, which is a homeopathic remedy that we were injecting into the trigger point. We weren't using cortisone or any type of, chemical. So you can have holistic, quote unquote, holistic services provided. That's, a lot of the things I did in my integrated practice was, vitamin and mineral injections, chelation therapy, these were all considered more holistic services. So with trigger point injections, 20553, very common code. I was telling you the osteopath that I had in my practice wasn't familiar with doing trigger point injections. He didn't know where to find them. As chiropractors, we're good with our hands. We could find those areas of tightness and areas of lactic acid buildup. So I would palpate the point. I'd put my finger on it. Then I'd tell the doctor, come over here, right here. You see where my finger is? That's where I feel you should be injecting. So I did a few with the osteopath. And then after a while, he was able to figure it out on his own. But there are courses. If your nurse practitioner has no idea how to do a trigger point, there are courses that they can take. We have a list of companies that will train your nurse practitioner how to do joint injections, stem cell injections. If you're going to bill Aetna for trigger point injections, get a hold of their policy, make sure that you're doing it right. And, for example, Aetna says, yeah, we'll pay for trigger point injections, but the patient should have gone through a little bit of conservative therapy, maybe some ice or massage, or maybe over-the-counter medication. They should have the pain for 3 months. That's considered chronic. And then go ahead and do the trigger point injections. Medicare, they have their policy on trigger point injections. This is the policy from Colorado, New Mexico, New Jersey, Pennsylvania, Delaware. Next, joint injections. There are small, medium, and large joints. Small joints are like the fingers and toes. Typically, you don't need guidance for those. That's 20600 with guidance 04. And then we have medium size joints like the wrist, elbow, ankle without guidance 20605, with guidance 20606. That's ultrasound guidance. 20610, large joint, shoulder, hip, knee, without guidance, 20611, with guidance. That's the most commonly one build that I see amongst my clients, 20611, if they're using ultrasound guidance. I do have some clients that are using fluoroscopy, so then you would use 20610 and 77002. I'm sorry, 20610 and 77002. There are many different types of items that get injected into the knee. these types of visco supplementation injections with Synvisc, Gel 1, Synvisc 1, many different types, and these are all J codes. These don't pay a lot of money, but these are billable, all these different J codes. These are HCPCS codes for the actual dose. And you could see there's different protocols. Like under the Synvisc, it's 3 weekly injections, 16 units per knee. And then you go with Synvisc 1, which is a single injection, but you bill that for 48 units. Certain modifiers are needed. So that's the information on joint injections. Now this is relatively new technology, amniotic fluid flow for inflammation. Now amniotic fluid has been used for many years for wound care during surgery or during an eye surgery. Fluid flow is used, but it's relatively new for the treatment of soft tissue injuries, ligament sprains and strains and trauma and pain and inflammation. The lab that I like that provides the fluid flow is called BioLab. There's a Medicare approved Q code for amniotic fluid flow injections. It's Q4206. Sometimes the patients need 1 cc, sometimes they need 2 cc's. If they need 2 cc's, then you bill that code twice. Q4206. Medical necessity. It's always about medical necessity. So if you're going to be injecting amniotic fluid flow, basic chief complaint, duration of the systems, past medications, any new diagnostic tests, physical exam, what does it show? The diagnosis codes. Next, platelet-rich plasma injections, PRP injections. So there is a code, however, it's a category 3 code for PRP injections, 0232T. See the letter T at the end of the code? That means temporary. T stands for temporary. So this code is being used, it's being billed by many providers. So what's going to happen is in a year or so from now, the AMA coding committee is going to make a decision. Do we have enough people billing for PRP that we're going to create now a bona fide actual CPT code, category 1 CPT code? Or are we going to just shelf this? For example, dry needling. Dry needling has been around for many years. There was never a specific code for dry needling. A temporary code got created, and now, as of last year, we have actual CPT codes for dry needling. There's a temporary code right now for low-level laser therapy, 0552T. There's no specific CPT code for laser, but we have a temporary code. If that temporary code is used a lot, then there will be an actual code. So that's PRP. Stem cell, I don't really get too involved with billing for stem cell because it's a cash service. Stem cell is not covered by insurance. At least 99% of them do not pay for stem cell. Amniotic fluid flow, if you're familiar with it, you can consider it a type of stem cell, but it's not. So stem cell is not covered by Medicare or any insurance company that I know of, but the joint injections are, trigger point injections, and the amniotic fluid flow is paid for by Medicare. What are the things that do I see in the typical DCNP integration? Is DME, durable medical equipment. That's what DME stands for. Back braces are also considered orthotics. Some people think, orthotics, isn't that foot levelers in your shoe? Yeah, but there's also lumbar orthotics, shoulder orthotics, knee orthotics. So lumbar orthotic is also known as an LO, lumbosacral orthotic as an LSO. So these back braces, these spinal orthotics, they're used to control movement. If the spine is unstable, the orthotic helps with stability. So read between the lines a little bit with that. If the patient has instability and a back brace would help the patient be stable, wouldn't an instability diagnosis code like M53.2X, that's lumbar instability. That would be a nice diagnosis code to assign to a back brace. See where I'm going with that? So the orthotics can be rigid or semi-rigid. Flexible orthotics, they're not typically covered. Like, you know, those Velcro straps you see in CVS or Walgreens for 40 bucks? That's not DME. Documentation must relate the patient's expected goals. The orthotic should be part of an active treatment plan. And now with back braces, there are off-the-shelf, OTS, and custom fitted. Different codes, different fees. Off-the-shelf does not require expertise of a certified orthotist. Custom fitted does. So there's the difference. Those the doctors that are doctors that work with us that are interested in becoming certified, authorized DME suppliers for Medicare, we recommend that you go through a online course to become certified fitter. It helps with your credentials. It shows proficiency. It's a weekend course. You get a certificate, and now you're considered a certified orthotic fitter, which allows you to sit for the national test if you wanted to become a certified orthotist. So a couple of side notes there. Here are some of the most common back braces. L0625, that's a lumbar orthotic, provides lumbar support from L1 to L5. And that's prefabricated off the shelf. And then we go to an L0627. This is custom fit. Now we have an LSO, L0631, lumbosacral orthotic. This is a very large brace. It goes from T9 all the way down to the sacrococcygeal junction. So if you're billing L0631 and the equipment manufacturer is telling you to use L0631 and you look at the brace and it's only covering L1 to L5, you're not using the right code. And then we have L0648, that's a off the shelf. PDAC, if you're going to get involved with DME and become a certified supplier, you want to get familiar with this term, PDAC, pricing, data analysis, and coding. It's through a company called Noridian, and they are in charge of authorizing HCPCS codes for DME. So I have a client. He's like, Marty, I am inventing a traction device in my garage. Like everything gets invented in the garage, right? So this chiropractor, he's like, yeah, in my garage, I have a little wood shed and I'm creating this traction device. I want to show it to you, Dr. Kotler, because I'm thinking about using it on my patients, and then I might want to, you know, mass produce it and sell it to chiropractors. I said, that's fine, go for it. But you're going to want it once you're finished with your device that you're building in your garage. I want you to send it to Noridian, and they will assign a HCPCS code to it. Maybe, maybe not. Hopefully they will. And then if they go, okay, so your traction device, Dr. Garage, is E0855. Beautiful. He gets something like this in writing. You see, this company sent a letter to Noridian saying, we have a back brace. This company called DonJoy, you may have heard of them. They said, we have a back brace. We want to get your opinion as to what code should be used for it. They come back and they went, all right, your brace is an L0631. Now, this could be used as a unique selling point. If I'm the manufacturer of the back brace, and I can say, here, nurse practitioner, this is the back brace, and we have an approved HCPCS code right from the federal government. You know, it's nice to get this letter. So when it comes to DME, you want to get their policies on billing and coding. This is Cigna's policy on DME. Read it. If you want to become a certified supplier of DME for Medicare, you and your nurse practitioner contact us. We do that. We'll fill out all the applications for you. It's not a simple process. It takes about 3 months to go through the process. It's about $8,000, yes. The accreditation process, all the application fees, training. However, it could be financially worth it once you get through the accreditation and certification process. Physical therapy, yes, your nurse practitioner is, well, is if you have a physical therapist in the office, your nurse practitioner may want to recommend physical therapy. Does your nurse practitioner want to do the physical therapy? They can. So let's talk about supervision levels. Qualified healthcare professionals include chiropractors, nurse practitioners, medical doctors, PAs, PTs. So qualified healthcare professionals are licensed individuals, well-trained, licensed, and can report services to insurance companies. Clinical staff, although may be licensed, wonderful people, trained, they cannot bill directly to health plans. So we call those clinical staff. Just make sure you know what the supervision levels are in your state. For example, Medicare does not allow a nurse practitioner to supervise a PTA doing physical therapy services. Yeah, you would think, why not? Yes, it's strange. PTAs could only work under PT supervision under the Medicare policy. So just make sure who can do what in your staff. CAs in some states are not allowed to do anything. In New Jersey, CAs, maybe they could put the stim pads on, but they really can't do much in New Jersey unless you're a licensed chiropractic assistant. I have a client of mine from New Jersey. I see that she's billing for ultrasound. I said, Doc, who's doing the ultrasound in your office? She said, my CA. I said, is your CA a licensed chiropractic assistant? She said, no, but my CA is a nurse. I said, Doc, it doesn't matter if your CA is a nurse, a medical doctor, an electrician, or a plumber. Your CA cannot do ultrasound, because sometimes doctors get a little confused. They think, oh, she's a nurse. She could do the ultrasound. No. So you want to check your state, who can do what. CAs in New York are very limited, really can't do anything. But if you bring on a nurse practitioner, now a nurse practitioner, you can bring on another nurse practitioner, you can bring on a physical therapist, you could bring on an acupuncturist. Yeah, this is right from Medicare. It says personnel authorized to provide outpatient therapy services. So we're talking about physical therapy services. Who could provide them to Medicare? MDs, DOs, nurse practitioners, physician assistants, physical therapists, occupational therapists. Then it says personnel not authorized to provide outpatient services. Aides, athletic trainers, exercise physiologists, massage therapists, recreation therapists, kinesiotherapists. No. Chiropractors, no. Rehab, no. Modalities. Supervised modalities, not time-based. You don't need to have one-on-one contact. So hot and cold and mechanical traction and unattended stim are the most common. There are photos there. Now your nurse practitioner may want to do vasopneumatic. There's a photo, paraffin, whirlpool, diathermy, infrared, ultraviolet, whatever suits your fancy. These are all payable codes except for the hot and cold pack by most plans. Constant attendance modalities, well, these require one-on-one contact. You could build these in units, one or more areas, each 15 minutes. So there's attended stim, iontophoresis, which is not in the scope for chiros, but it is for nurse practitioners. Contrast baths, ultrasound is the most common. Hubbard tank, that's that butterfly-shaped tank in the bottom right corner there. Contrast baths is alternating hot and cold. We have therapeutic procedures. Things change here because you don't need equipment. When I first started billing therapeutic exercises, patients just lied on the floor. So you don't need equipment like with modalities. So it's your intended outcome. What are you trying to accomplish? So there's many different therapeutic procedures here. Most of them are active. Therapeutic exercises, active to increase strength, endurance, range of motion, flexibility. 97112, neuromuscular reeducation to improve balance, coordination, kinesthetic sense, activities of daily living, therapeutic activities. These are all codes that your nurse practitioner can bill. If you don't want to get a physical therapist, Nurse practitioner can do these. These are passive. I doubt highly your nurse practitioner is going to be doing these certain hands-on type services. Maybe. That's up to you and your nurse practitioner. Now, when it comes to timed codes, these time-based codes, 1 unit is 8 to 22 minutes. Doesn't have to be 15. 8 to 22. If it's less than 8 minutes, shouldn't bill at all. If you do ultrasound or therapeutic exercises for 7 minutes and 59 seconds, you shouldn't bill it at all. A little bit about compliance. There's 2 types of compliance in my kind of world. There's billing and coding compliance and HIPAA compliance. So the main purpose of HIPAA compliance is to protect patient health information. The main purpose of billing and coding, also known as OIG compliance, is to prevent billing and coding errors. So if you see Medicare patients, even just as a chiro, even if you're not integrated, you should have a billing and coding policy and procedure manual. One of the most important things is doing self-reviews. Another thing is documenting your trainings. 3 hours per year is what the OIG says. Any person in your office, it could even be your front desk CA that has anything to do with Medicare patients. So for example, your front desk assistant is taking copays from Medicare patients, is entering codes into your EHR. Let's say your front desk CA is Shelley. She seems terrific. Shelley is a wonderful person. Put Shelley's name and her first and last name in the Medicare OIG exclusions list. The website is exclusions.oig.hhs.gov. Hopefully her name doesn't pop up as being excluded. If her name pops up, you shouldn't have her dealing with Medicare patients at all. Do background checks. Here, if you wanted to hire this chiropractor to see your Medicare patients, you would be making a mistake. This chiropractor is excluded. I ran this chiropractor's name through the exclusions list. It says excluded, and it gives you a reason. This chiropractor defaulted on his student loan. If a chiropractor doesn't pay their student loan, they're kicked out of the Medicare program. Yeah, I know, it's something you're probably hearing for the first time. Yeah, you want to see this. No results, right? You want to print this out, put it in your manual. So just some basic things like, do you offer free services like free exams, free stim, free x-rays? Do you have a policy on it? You should. This chiropractor got in trouble. He was offering free stim to his Medicare patients and he got fined $80,000 for doing that. Do you have a policy on discounts? Like, Mrs. Jones, our normal fee is $100, but for you, it's only 80. You know, like, do you have a policy on that? We like to use this OIG document that talks about discounts, prompt pay discounts. What about copays, coinsurance, deductibles? Is it okay to waive copays, deductibles, and coinsurance? The answer is maybe. Depends on the situation. The routine waiver is not okay. Like all my Aetna patients, I'm not collecting the copay. All the patients that work for Google, I have 200 patients that work for Google. They have great insurance. I'm not going to ask them to pay the copay or deductible. Just come on in. See, that's not okay. Here, look at this chiropractor. Got a letter. Dear doctor, after contacting some of your patients, it has come to our attention that you routinely waive all patient responsibility. Ooh, that's not a good letter to get. Doctor, please supply us with copies of your billing and collection ledgers. Show us documents when bills were sent to the patient, if any, and how much has been paid by the patient, if any. This doctor was telling his Cigna patients, come in, don't pay anything. Cigna found out they want $300,000 back. They called it fee forgiveness. You have a policy on Stark and anti-kickback. I'm not a lawyer. That's where you need Matt to help you with Stark and anti-kickback. So we're into prevention. We like to be proactive. We don't want to wait for the oil light to flash on the dashboard. We want to get out of the car, open the hood, ask yourself some of these questions. Do you conduct formal meetings on a regular basis with your staff? Do you conduct trainings with your staff on how to collect copays and deductibles? Do you do background checks on all employees and your billing company? If you use a billing company, run your billing company through the OIG exclusion list. Do you have all your staff members trained on the different levels of supervision? What happens if a patient has a concern about your billing policy or they think you violated their HIPAA rights? Do you have a policy in place how to handle that? How about all your business associates? Do you have a list of them? It's required under HIPAA. All right, so before we get into some other closing comments, let's take a look and see what questions have come in. All right. First question is for Matt. Are you there?
Yeah, I'm here, man. I'm here, Marty.
Okay, first question here is, can a chiropractor, oh, what does this say here? Can a chiropractor employ, oh wait, can you partner with I'm trying to read this, doctor. Can you partner with a nurse practitioner in New York? Does it need to be a management setup? I think you answered that already. They can partner.
Well, I think there are two different structures, right? So, in New York, you would form the, professional limited liability company, and you wouldn't need to have a management company. The management company, for example, you have these MDDCs where, we know that in New York, a medical doctor and a chiropractor cannot be partners. Sometimes what chiropractors might do is they'll provide a management company to provide sometimes even a turnkey operation. They'll provide the space, the furniture, fixtures, equipment, as well as the non-professional support staff. But there are limitations, as Marty said in the beginning of this discussion. There are pros and cons to everything we do. Every model has its pros and cons as well. And that model, the management model, has its limitations. That arrangement must be a fair market value arrangement, and that is a discussion that could take an hour to an hour and a half for sure.
Right. Okay, here's a good one. Chiropractor is also a nurse practitioner. Can we bill under the nurse practitioner info and not have any issues? How does that work?
Wow. So are you saying that we have one individual that has dual licenses?
Yes.
Well, so obviously, in whatever capacity you're treating that patient would be what you're going to bill under. I need to know some more facts, but if you're seeing, and again, how you hold yourself out to the public or to your patient is crucial as well, especially in that case. Are you holding yourself out as a chiropractor, or are you holding yourself out as a nurse practitioner for the services that you're performing?
Yeah, I guess, patient comes in with back problem. The chiropractor puts on his chiro hat, adjusts the patient's lower back, bills the insurance company on that claim. And then this patient also has knee inflammation. The chiropractor then puts on the nurse practitioner hat, takes out a different chart, does the knee injection and does the knee work. That's a separate claim, separate diagnosis, separate claim. Yeah, I guess that's fine. Okay, next, can a New Jersey MD oversee a New York nurse practitioner for collaboration?
So if that physician is not licensed in the state of New York and the patient is being treated in the state of New York, the answer is no.
Yeah, I would have answered the same way. Okay, are these notes, do you recommend a certain system? Oh yeah, so for EHR, yes, I like Genesis Chiropractic Software. That's the company I like. People are asking me what software I recommend. That's not really relating to this topic, but I like Genesis Chiropractic Software. Let's see what the next question is. One person is saying there's no sound. If one person says there's no sound, that means there is, because nobody else is saying it. Are the CPT codes for injections for administration of the injection along with the product that is being injected, or you deal administrated separately? Yeah, it's separate. You have the J code and then you have the injection code. Next. Oh, does Genesis Chiropractic, does Genesis Chiropractic software allow for e-prescribing? I don't know. Good question. Contact them directly. I think that was the last question. So let's take a look and see what else here. Besides these webinars, target coding, we also offer boot camps, CA boot camps. We try and cover every possible job description a CA can have. We have memberships, basic, silver, gold memberships. We have a lot of testimonials. This was a sad testimonial. This Dr. Spina, he's in big trouble, probably going to jail. And he wrote me a testimonial saying, Marty, I should have listened to you. Sad, but he gave me a testimonial. It says, after 38 years of practice, my life is ruined and that of my family because I thought a compliance plan was not needed or was not important. I see the damage I've done to my patients and my community, so it's a testimonial, but kind of a sad one. Oh, yes, I wrote a book on the best codes to improve reimbursement. It's an excellent book. Hopefully it'll be a movie one day. I also have forms. You could have the best software in the world. You still need forms, ABN forms, HIPAA forms, letters of medical necessity, fight back letters, consent to treat, financial forms. So we have a forms pack. It's $199. What else? We do billing. Yes, we do billing. If you want to outsource your billing to us, maybe you just want to outsource your billing for joint injections. We'll take you as a client. Maybe you just want to outsource us for your DME, for your back braces. You don't have to give us all your billing if you don't want to. So contact us if you want us to help you with billing. Yeah, you bring on a nurse practitioner that doesn't have a PTAN number. We can get you a PTAN number, CAQH. So we do credentialing here at Target Coding also, a little bit of credentialing. And seminars, webinars. So just a few more closing comments. I don't know if any other questions come in. I'll check in a second. Check with all the carriers you bill prior to submitting claims based on this information to ensure it's in compliant. Target Coding and Matthew Levy's law firm does not guarantee that the information provided in this presentation will guarantee payment from any insurance company or patient. Matthew Levy's law firm and Target Coding is not responsible for any laws or rules that may change following this presentation, and they change all the time. So do your best to stay on top of these changes by attending seminars, webinars, and joining your national and state professional associations. So I want to thank everybody for attending. Stay in touch with us. Follow us on Facebook and Instagram. Go to YouTube. I have over 100 free videos on YouTube. Go to YouTube, in the search, put in Target Coding. You'll see my YouTube channel. Subscribe to it. Here's my contact information. Email info@targetcoding.com. Website, targetcoding.com. Telephone number, 1-800-270-7044. Fax number, 1-844-831-2347. That's our HIPAA secure fax number. Matthew, any closing comments?
Just Marty, wanted to thank you for having us. As always, if any participant, of this presentation has any questions, please don't hesitate. You can give me a call. My direct line, area code 516-926-3320, or you can email me at mlevy@weissarett.com, MLEVY@WEISSZARETT.com. If you have any questions about whether they're employees of yours, whether they're audits, whether there's an investigation, anything related to the practice, please don't hesitate to give us a call.
Excellent. And by the way, if those of you that maybe fell asleep during the presentation or couldn't make it through, or you want to show it to your staff members, this was recorded. We're going to be putting it up on our YouTube channel and on Instagram and Facebook, all of our social media platforms. We're going to get it over to Matt Levy, and he might want to send it out to his list. So yeah, so just in case you didn't catch everything, check out our YouTube channel in about 2 or 3 days, and you'll see this presentation uploaded there. So again, I want to thank everybody for attending. I hope you learned a lot. Take care, everyone. Bye-bye.